Hello, my name is Ran Mahmood and welcome to Thyroid Trouble, where we'll talk about the complications of thyroid surgery. Why? Because these complications can be prevented or reduced with the proper knowledge of anatomy.
We will learn about the vasculature to avoid bleeding complications. We will learn about the location of the parathyroid glands to prevent hypoparathyroidism. And we will learn about important nerves nearby that innervate the larynx to prevent airway and voice complications.
So the thyroid is a bow-tie-shaped organ around your trachea connected by the ligament of Berry. There's a right lobe, a left lobe connected at an isthmus. So let's see our thyroid.
Our thyroid is different. He's wearing a hat that he's using to cover his pyramidal lobe. Now the previous thyroid did not have one. You can think of it like, just like you can divide people into those who like to wear hats and those who don't, roughly half of thyroids have a pyramidal lobe and half do not. This, like a thyroglossal duct cyst, is an embryological remnant and important to look for if you want to make sure you don't leave any remnant thyroid tissue behind in a thyroidectomy. The other thing to remember whenever you see the thyroid is he always has company behind him, the 4 parathyroid glands. They will be important to keep in mind during surgery so that you don't accidentally cause them injury as well. Okay, now except for certain genetic syndromes such as MEN2, we won't operate on healthy thyroid. So what pathology should we give you? So a thyroid nodule can be many things: a cyst, a multinodular goiter, an adenoma, and unfortunately in about 5% of nodules, cancer. We can induce this through radiation from imaging.
Clear? Okay, so let's make you remember that a history of net irradiation, among other factors, is something that would push you to do a total thyroidectomy if the workup suggests malignancy. So we have a problem and we have a procedure. So let's take it to OR.
We'll start with an incision along a neck crease. As we go down, we'll quickly review the neck muscles. The first muscle we encounter is the platysma. You can visualize if you pull on it, it is going to give you this expression. Let's take it down. The sternocleidomastoid is attached from the sternum to mastoid process in the back of the head. So if you pull on it, it is going to flex the head to the same side and rotate away. Now let's look at the strap muscles of the neck. We have the infrahyoid muscles because they are below the hyoid bone. Since they are below, the omohyoid and the sternohyoid are going to depress the hyoid. Next we see the thyroid cartilage, which is actually above the actual thyroid gland and covers the larynx. The sternothyroid, being below, is going to depress the thyroid cartilage and hyoid bone. The thyrohyoid muscle is in between, so it is going to depress the hyoid bone but elevate the thyroid cartilage. We see our thyroid, and to cover our first complication on bleeding, we will learn the blood supply. The thyroid is drained by a venous plexus. These drain to the superior, middle, and inferior thyroid veins. The superior and middle first drain to the internal jugular vein. These then all drain to the brachiocephalix. It is the same on the right as it is on the left. For the arterial supply, let's remember the branches of the aortic arch. We have the brachiocephalic, the left common carotid, and the left subclavian. Looking at the left first, the superior thyroid artery is going to come off the external branch of the common carotid. The inferior thyroid artery is going to come off the thyrocervical trunk from the subclavian. For the right, you just have to remember the brachiocephalic is going to divide into the right common carotid and the right subclavian first. And then it's the same thing. The superior thyroid artery from the external branch of the common carotid, the inferior thyroid artery from the thyrocervical trunk of the subclavian. But wait, in 3 to 10% of the population, you will also have a thyroid ima artery. And even though it is small, it can come off any of the branches of the arch or the arch itself, so it can lead to significant bleeding if not accounted for. Okay, now remember those organs I told you not to forget? Yes, the parathyroids. And since they get their blood supply from the same vessels, usually the inferior thyroid, you want to make sure you cut off the small branches to the thyroid as close as possible so that the parathyroids don't also get ischemic or injured. If you are worried about the viability of the parathyroids, you can perform something called an autotransplantation of the parathyroid gland. Which one of you should I demonstrate this on? Let's pick this one. So autotransplantation is taking a parathyroid gland and chopping it into very small pieces. These small pieces are able to cause neovascularization and survive, unlike a whole intact parathyroid gland. So you can then put them back into the neck muscles. The last complication we will discuss is nerve injury. So from your vagus nerve, you have recurrent nerves coming back to the larynx. The right recurrent loops under the right subclavian, or at the distal bifurcation of the brachiocephalic. And the left recurrent loops under the aortic arch. These travel along the tracheoesophageal groove and innervate all the intrinsic laryngeal muscles, important for breathing and voice, except for the cricothyroid. The cricothyroid is innervated by the external branch of the superior laryngeal, which runs in the superior thyroid artery. Most of the injuries are going to happen because of variations. For example, the recurrent laryngeal might travel anterior instead of deep to the inferior thyroid artery, or it might be intermingled, or it might be not even recurrent at all, a non-recurrent recurrent laryngeal. To see the effect of these nerves, let's take a different view from above. So the recurrent laryngeal is going to innervate all the muscles in beige. You can see it is important for breathing and voice. If you injure one side, say the right, you can see how you would have difficulty breathing, and your voice will be hoarse. And you can see how bilateral injury is going to close off your breathing. And remember, the recurrent is also important for voice. The external branch of the superior laryngeal innervates the cricothyroid muscle in pink. And you can see if you pull on this muscle, it's going to tilt the thyroid cartilage forward and therefore stretch the vocal folds. Now you can see your voice is going to be a higher pitch. So damage to this nerve will prevent you from hitting those higher pitches. Okay, while we close, we can summarize the 3 complications. So we would look for bleeding during the procedure, or development of a hematoma afterward, which would mean immediately reopening the wound and a trip back to the OR. We learned about hypoparathyroidism, so we can keep track of calcium and parathyroid hormone. And then for breathing and voice, we can listen to our patient's voice. So why don't you sing for us? Okay, so that doesn't sound too good, but transient hoarseness is expected. So we can give it some time to rest. And how about we give it another go?
Thank you.